Welcome to our last part in our video series. This is an advanced tutorial series on monitoring hormones, and this last piece is on one of the most controversial and difficult topics that we deal with, monitoring transdermal hormone replacement therapy with not just our Dutch test, the dried urine test for comprehensive hormones, but also with serum and saliva testing. And this is a subject I've spent years digging into and trying to figure out, what should we really be doing as we go back to our matrix that we've been working off of when we've got transdermal hormones. What happens in serum, what happens in saliva and urine testing, as well as our own version of urine testing. And what I've found is that none of these tests work tremendously well for monitoring a dose and changing a dose to get a better clinical outcome. And so we're going to go through the data that I use to support that conclusion and talk about each of the tests and what their strengths and weaknesses may be if you want to use them to monitor topical hormones. So can testing help to monitor dosing? That's the question, and it is tricky. The short story is this. You take a transdermal hormone, especially with the creams, you get a small, if at all, increase in serum or urine. Probably based on the other data, it's probably an underestimation of some sort of tissue levels of hormone. At the same time, you get huge increases in salivary hormones. But those values are way too variable to use them for monitoring doses. And as you really dig through the data, I think there's a lot of doubt as to whether that really reflects systemic tissue levels well. So that doesn't leave us with a strong option, and that's sort of the bottom line here. Now, the long version, we're going to go through this in great detail so you can really understand how we come to the conclusions that we come to, and again, also talk about how to best use the testing when you do want to monitor these hormones. So the increase that we see depends on where you look. You get a small increase, as we said, in urine and serum, and a huge salivary increase, and also in capillary blood spot. So this study, where we looked at percutaneous progesterone delivery, which percutaneous is too big of a word for me, so I'm going to switch in transdermal. So transdermal progesterone delivery, okay? And we looked at serum, whole blood, that's venous whole blood, saliva, and capillary blood or blood spot. I just put this in there to show you that I was actually a part of this study. So we looked at these different body fluids and said, okay, where's the progesterone going? And what we found is really, really different results when we look at saliva and blood spot over time. So these women had put on progesterone on their thighs, 80 milligrams every day. And then they came in, being 1 day removed from their last dose, and they tested. And then they put on the hormone, and they tested throughout the day. And what we found is a huge, massive increase over baseline, about 100-fold over a true baseline value for blood spot and saliva. Serum and urine was not part of this study, but we can infer what's going on there from other studies and from our own data. It doesn't go anywhere with progesterone. Okay, so it's a little bit different with some of the other hormones. Progesterone is the most extreme, so it's the most interesting to study, and we get this complete dichotomy, totally different message depending on which value we're looking at. As I dig through all of the data that I've observed from both published and unpublished studies, this is the position that we take. Saliva teaches us that some tissue have more, and sometimes far more, hormone than is reflected in serum or urine testing. But it may not, and I would go as far as say it does not reflect systemic levels. And is it effective in monitoring HRT? I think the answer to that is no. That's what the data shows me, and we're going to go through that. But first, let's pause and take a step back and say, okay, if some of the tissue have huge levels of hormones that are not seen in serum or in urine, then we've got a problem, because we want to avoid what we call testing minions. And this is just a kind of a cute way of saying, look, if there's a situation where something's wreaking havoc on our ability to monitor systemic hormone exposure with laboratory testing, we've got a problem. And this is a big one. For transdermal creams, it's a little bit different with alcoholic gels, but with transdermal creams for sure, I think you can say with some confidence that serum or urine testing have a big problem in terms of potentially underestimating what's going on at the tissue level. And we need to take that into consideration when we're using these products and monitoring them this way. So that leaves saliva testing and to some degree blood spot testing. So as we look at this data, we see again over time after the dose, there's this big increase. If we move on to this and say, well, what happens if we look at the average value at all these different doses? Well, we don't get anything in serum. If you get out here to 200, 400, 600 milligrams, you're going to start to see an increase. But over the same time, you're getting a linear dose-dependent response in saliva, which to me was pretty compelling. But when you look at the data in here, it's really variable, right? So it's going to bounce around a ton from person to person. And what we didn't know initially is how much of that variability would you see within one single individual if they simply tested multiple times? And that's really where this falls apart, is with transdermal hormones, the saliva and blood spot have some significant minions, some significant issues that really make it not a very robust method of monitoring hormones. The first is contamination, much more problematic with blood spot, but also with saliva. I've done saliva testing on myself in different situations, trying to put on a hormone, monitor the hormone over time, and the contamination problem was definitely an issue. But if you are very careful, you can eliminate the contamination issue. But you still have, I think, insurmountable odds with these two. Primarily the first, sample-to-sample variation. So in this study that's published, here's the data for blood spot. So what we did is the people put on hormone, and they tested, over the course of the study, they ended up testing 3 times in blood spot in the testing window that a lab would normally ask you to collect in, 12 to 24 hours after supplementation. And if you take those 3 values, those are the values that you as a practitioner would get in your practice from the patient, right? So these are the types of values you get. From the 14 participants that had all 3 values, 2 were eliminated, so about 15% were eliminated because of contamination. Now that also shows you that contamination is a significant issue. In this study, hormones were put on by a third party with gloves on the thigh, so far away from the sampling place, blood spot, saliva gland, also in a place that's covered subsequently with clothes. So this is best case scenario for eliminating contamination, and 15% of the data was eliminated from consideration because of contamination. If you look at who's left and you look at the replicate values, it's a problem. Participant number 1 has 3 values, a low value, a normal value, and a high value. Now, these are all taken in the testing window. These are the types of values you would get as a practitioner. So, does this patient have low, normal, or high values? We don't really know. And as you look through these, what you'd find is of the 12 people left, a full 6 out of 12, 50%, have both a high and a low value when testing 3 times. That's not helpful. Blood spot is not reproducible enough with a transdermal cream to make good decisions. Is saliva reproducible with transdermal creams? It really isn't. If you look at, let's just go right to the data, but the point is, if you give what we're calling here typically the just right dose. If you give them just the right amount of hormones, but you have a testing minion of sorts wreaking havoc and making these results highly variable over that time period, and this is the same dose and the just repeat collection in a same time window, after supplementation, what do you make of this? It's not really going to work. If you had a patient who simply decided, hey, doctor, when you put me on hormones, I'm going to get tested. You said, fine, that's what I want. They said, well, I have a lot of money. I'm going to get tested extra times. You said, okay, if you want to waste your money, that's fine. But if they came back from that experiment and said, well, I tested 3 times just like you told me, and I got a low value, a high value, in a normal value, there's nothing you can do with that. The problem is, in a clinical practice, you always just get one value, so you have to assume that it well represents their general exposure to hormone. And what you can see from this study, if we just go to the data, is we have 2 collections that are pretty much identical to what you might get and identical to each other. They took the hormone on one day, 24 hours later, they collected. Then they took the hormone again, and 24 hours later, they collected again. So these 2 collections are as similar as they can be to one another. So on collection 1, there is both a blood spot and a saliva value. Collection 2, a blood spot and a saliva value. And what you'll see is it's 2 things. One, the blood spot and the saliva don't really agree with each other all that well. So that's a problem, but the bigger problem is just how variable they are. If you look at patient number 7, this is what we expect to see, but it's really the only patient that has that level of reproducibility. As you get a pretty normal value in blood spot, a 9, and then another normal value, a 10. And in saliva, you get a 160, which is kind of low normal for topical hormones, and then a little bit higher for collection 2. All the values are within twofold of each other, but go down one more patient and you'll see what worst case scenario looks like, which is just as prevalent as this best case scenario, and that is the first collection, you get nearly a 50 in blood, which is pretty high, probably too high. But in saliva, you get a relatively low value. So you say, okay, that's two completely different messages. Let's collect again. So the next day you collect again, and the blood spot is 10 times lower, and it's a low value instead of a high value, but the saliva has gone in the opposite direction, tenfold up. Fivefold increase, or just change, a fivefold decrease from one collection to another is the most common scenario in this data. And that really is a problem, because if you're not getting the same message from one collection to another, and again, this is in a controlled setting, it just doesn't work well enough to get a value and change your therapy. So the other issue that we have with this type of testing, and this is where it really starts to reshape our understanding of how is that hormone actually getting into the tissue, is, we look at this and say, okay, look, if I give 20 milligrams of progesterone, I'm about 500. If I give 40 milligrams, I'm at about 1,000. So I double the dose and I double the value. But what happens if, when I give this just right dose, what if I can increase the value even more than the dose would increase the value with the same dose, just by moving where the hormone is? So look at this data, and you can see that, change my color here. You can change that. See that when this person put hormone, testosterone, up around the collarbone, which is very close to the saliva gland, they got a huge value. When they moved it further away and further away, the values came down. Now, these are peak values. These are not at 12 hours or 24 hours, but it shows you that, and this is a logarithmic scale, right? So that's a huge, massive difference in terms of how much hormone gets into the saliva gland based on where you put the hormone. And presumably the same thing would be true of blood spot. If you put the hormone on your forearm right next to your fingers, or you put it on the thigh far away from your fingers, potentially the data would be very different. We don't know. That's never really been looked at. But this raises another question of, this is not a standardized sort of thing. If you're moving the hormone around, the value can move around a lot, which one shows you that there's a little bit of a problem in terms of just getting a value and changing the dose if that's not standardized, and it's a bigger effect on the results than the dose is, right? So if you put the hormone here and the value is very high in the saliva gland, and you put the hormone over here and it's a much lower value as it has to travel a further distance, that would be the interpretation, is it has to travel a further distance. So this is really interesting, and we don't want to go into it too much, but it really starts to reshape your understanding of, are these hormones getting in to systemic circulation and then dumping into the saliva gland so that it represents tissue level? Or are they diffusing sort of through maybe lymphatics, through subcutaneous fat, whatever it might be, or maybe a combination thereof? If that's the case, then it really shouldn't be expected to represent systemic levels. If I put the hormone around my neck and get a high value, and I put the hormone around my thigh and get a much lower value, would that represent what's going on in the uterus of a woman as she puts the topical progesterone on her neck? Would you expect a much higher value than if the hormone's applied to, a place closer to, the site of action? It doesn't make a lot of sense. So this data is really starting to kind of reshape how we understand the hormone gets there. The other issue is it's so fat soluble that you can see that in this study for 12 weeks, after cessation of treatment, that's still a very elevated progesterone value. So that's kind of interesting. And some studies have shown, or some data has shown, elevated values as long as 6 months after the cessation of therapy. Here's a gal who's testing throughout the menstrual cycle, she quit using progesterone here and then collected throughout the menstrual cycle. And you can see these values in the luteal phase are enormous. Normally you'd be around 200, maybe 300, 400, 500 at the most, but she's getting up around 35,000. Why? Well, presumably because the progesterone is sequestered somewhere and it's getting released at some time into the saliva gland. Now, is that interesting intellectually and academically? Absolutely. But should we then say, well, at this point in time, your uterus or your breast tissue have this absolute flood of progesterone that, it's not really known. It doesn't make a lot of sense. And so what these values mean, I think, is a lot more questionable than maybe what we thought originally when we started looking at this just story of what goes on at the tissue level or in the samples when we're using therapy that's transdermal. But at the end of the day, when you've got these three issues that are so significantly affecting results, much, much more so than an increase or a decrease to the dose, then it's just not an effective tool to monitor therapy. So if we want to look more practically and say, well, what's happening in terms of the systemic increase of hormone, this is a good study to look at. So what they looked at is LH values. So these are men. These are hypogonadal, so that LH value at baseline is an elevated value, right? Because their testosterone's low and their brain is saying, man, we need more testosterone, and it's pumping out the LH to tell the testes to make testosterone. Now, when we give 50 milligrams of transdermal testosterone, the LH values come down to here. Now, that is a normal. We've gone from high to normal. Now, at the same time, the serum and the urine have gone from low levels typically up into the reference range, which is sort of the same story that we're telling here with the LH. We're going from a state of testosterone deficiency, or LH excess, to a state of testosterone being more normalized where the LH is normalizing. But the saliva results at that dose go above a 1,500% increase, 15-fold. Right? So if at this point here, at 30 days, if there really was a systemic increase in testosterone that was 15-fold, then the LH values would come way, way down to zero. I mean, when men take injections of testosterone of 100, 200 milligrams weekly, which is much less of an increase than 1,500%, the LH goes all the way to zero. So the LH data doesn't really tell the same story as what's going on in the saliva gland. So that's kind of interesting data. The other data I think is worth discussing is there's one particular study where they put topical progesterone on, and what they found is that the levels of progesterone in the breast increased 100-fold. Now I used to find that very compelling to say, hold on, if I put topical progesterone on and the saliva values go up about 100-fold at maximum, and if I put topical progesterone on and the breast levels of progesterone go up 100-fold, that's a very compelling story that says that the saliva gland is sort of speaking for the tissue. It's a surrogate marker for what's going on at the tissue level. The problem with that is when you dig through the study a little bit more carefully, what you find is in that study, they put the transdermal progesterone right on the breast. So we're not talking about hormone going on the forearm and then increasing levels in the breast 100-fold and simultaneously in the saliva gland. We're talking most logically about a big local diffusion of hormone from that place where it was put on into the breast into the direct breast tissue. So that can be a little bit misleading to say, that what's going on in the saliva is reflecting what's going on in the tissue level. So I just want to point out that study because I think it is a little bit misleading to say that that's reflecting what's going on at the tissue level because of those values. But again, probably more likely local diffusion, especially as we look at how the saliva levels of hormones go much, much higher as the hormone is put on close to the saliva. So all of these things help us understand what is going on with transdermal hormones and how we should dose it and all of those things. But when you jump over that issue to ask, once I put it on, which lab value can help me monitor it, that's where I think you have a challenge. In serum, I really think it's probably a clinical underestimation, so be careful of overdosing. Same story with urine hormones. The metabolites might help you in those cases in terms of understanding what's going on a little bit and with relative metabolism, but in terms of taking testosterone and measuring testosterone, I think that's also a clinical underestimation. With saliva, you get these super physiological levels, but they're highly variable, probably not representative of systemic levels, and then also frequently contaminated. So what do we do? I think the first message is don't be chasing lab values with topical creams. Now, one point that should be made is if you're using alcoholic gels, it's a little bit different. So if you want to just be practical, if you're using saliva and blood spot with low doses, it can work a little bit better than with the higher doses, but when I say low dose of progesterone, I'm talking about less than 100 milligrams because the urine and the serum really aren't going up to those doses. But, the study we looked at was 20 or 30, no, that was 80 milligrams of progesterone. And you can see, again, the values are just bouncing all over the place. So that's really pretty problematic. You can use urine for the larger doses, and those values will start to increase, but I think you've got to be careful that you're not overdosing. When you use alcoholic gels, as I mentioned, Androgel, Estrogel, and some of these products, there is a more intuitive increase in urine values for sure. We definitely see that. So, it's still kind of a complex subject, and we probably best to use pretty conservative sort of target values if you're going to use urine, and definitely if you're using serum with transdermal products. A lot of people go into different routes of administration if you want a lab value to hang your hat on, so to speak, as you're monitoring these things. It might be advisable to use a mucosal membrane like vaginal hormones or transrectal to switch to some other route of administration. Patches, it should be noted, are very different than transdermal creams. They drive up serum values, they drive up urine values, so that's something definitely to know. But know the limitations of these tests. It's not a situation where you can have a rock-solid lab value and you just shouldn't be chasing values when you're using topical creams. So as we look through this testing matrix, so to speak, you can see there really aren't any great recommendations in terms of what's going on with transdermal hormones and monitoring with different tests. So it is somewhat problematic. I'll show you just a case study real fast for what we see with urine testing. Here's a guy taking transdermal testosterone. Now look at his testosterone. It's low. There's really no increase here. He's only taken 10 milligrams, but there's really no increase here. So what do I make of that? Well, I would see that as a bit of an underestimation, but because of what we just said. But what I do know is if testosterone gets taken up into a cell, it's got two options in terms of metabolism. It can go down this pathway, and it can make DHT, which is a more potent androgen, and then it can keep going this way, and this is the terminal metabolite. It's not terminal, but that's the end downstream metabolite of testosterone. Now look how high that value is. So to me, this implies that there's a decent amount of hormone heading down this pathway. Do you see it as testosterone? Not really, but if it goes into the cell as testosterone, it's going to emerge as a downstream metabolite. Now, I think that works relatively well for testosterone in terms of monitoring, but to be honest, I don't see the same sort of response with estrogen metabolites as you're taking transdermal estrogen. And with progesterone, I have measured every metabolite under the sun, probably 10, 13, 14 different metabolites in every different direction. None of them increase with transdermal progesterone, which I think it's then hard to believe that there really is a huge increase at the tissue level. Yes, in some tissue, but systemically, if you have systemic increase in progesterone, it has to go somewhere. Within the cell, it's going to go down the 5-alpha pathway. I've measured all those metabolites. It's going to go down the 5-beta pathway. I've measured all of those. There's a third pathway that makes 3 different pregnine metabolites. We've measured all of those. None of them go up substantially in the average case of someone taking 20, 30, 50 milligrams of transdermal progesterone. So it's still a pretty cloudy subject. More research needs to be done to understand it. But once it is understood better, is it lymphatic transport? Is it red blood cell transport? Once we understand that better, you're still left with the limitations of all of these tests that we've just described. And I think you got to be really careful in putting a lot of weight in any lab test when you go to monitor dosing with transdermal hormones. So I hope that's been helpful. I know this is a really difficult subject. We try to be just objective about it and just sharing the data that we have available. You can make your own decisions as to how that plays out in your own practice. But I hope this has been helpful. And if you have any input, even if it's contrary to what we've been saying, would love to continue this conversation, because it is a conversation that within the industry needs to evolve and needs to progress so that we're making the best decisions we can for our patients, whether that involves laboratory testing or not in this given situation. There's a lot more to learn. So thanks for your time and appreciate it.